Hello and good evening. So we have a wonderful program today. I'm so interested in it, thinking about the clinical experiences of children with ADHD and possibly undernutrition. Thinking about what we're going to do today and who we're going to hear, well, I will give a brief introduction and give you the definitions of ADHD. Dr. Rasmussen will be talking about clinical experience in nutrition-related issues with ADHD medication. Dr. Hoffmeyer and Esther von Ryden will be talking about nutritional management of children with ADHD who are at risk of malnutrition. We will close with a Q&A session where all of the webinar presenters will be able to answer your questions. So our first poll then, and please do participate. Yep. Are you familiar with the risk of undernutrition in children with ADHD and pharmaceutical treatment due to the side effects of appetite loss and weight loss? So you can only tick one box here. 1, I have no to limited awareness and want to know more. 2, yes, I'm familiar, but it's not relevant in my daily clinical practice. 3, yes, I'm familiar, and I believe management of such nutritional challenges is important. So please press now and give us your answers. And we have some answers already. Yep. So mainly it is people who are familiar and do believe that management of nutritional issues are important and just want to have some more information. And we have some people, of course, who have limited awareness and really want to know more. So let's see how we go with that. So why have I been asked to introduce this? I run a clinic in the UK, and it's a feeding clinic for children with avoidant eating, and many of the children that I see also have ADHD. So I work with children with ADHD and autism who have extreme avoidant eating outfit. So firstly, we need to think about what defines attention deficit hyperactivity disorder. So of course, those who don't have experience of a child with ADHD might say that it's not a mental health condition, but due to the child being naughty or lazy, poor discipline from the parents, or too much screen time and too little time outdoors. Of course, it's different for those of us who work with children with ADHD. So our questions are, how do we define the disorder? How should we treat this disorder? What's the impact of the disorder on the child and the family? Should we be giving medication? And what are the side effects of medication? So going to DSM-5 for our definitions, we have 2 basic types of ADHD, as it were. They were put together. They used to be inattention and hyperactivity disorder. It's been put together under one umbrella term. And it's a persistent pattern of inattention now, or hyperactivity, impulsivity, that interferes with functioning or development. And for a diagnosis of 1, inattention, 6 or more of the following must be noted in the child for the past 6 months. They're often distracted by unrelated stimuli, just as you are distracted by the squirrels. They fail to give close attention or make careless mistakes. They have problems keeping attention in the classroom or play activities. They don't seem to listen when spoken to. Their mind seems elsewhere. They fail to follow through on instructions and finish schoolwork and tasks. They have difficulty in organising tasks and activities. They avoid tasks that require mental effort over a long period of time. And they lose things necessary for tasks. They're forgetful. Now, all of these can cause problems at school for the child. They cannot attend to what the teacher is saying, and it will have an impact on educational achievement. Type 2, hyperactivity and impulsivity, we have to have 6 of the following. The child will often fidget, tapping hands or feet, often leaves the seat when they should be seated. They run and climb when this is inappropriate. They're unable to take part in leisure activities quietly. They act as if driven by a motor. They're uncomfortable with being still. They talk excessively. They blurt out the answer before the question has been completed. they interrupt. They have difficulty waiting their turn in line or in traffic with adults. They interrupt and intrude on others. They take over what other people are doing in games and activities. The behaviour can be a danger risk. The child runs into the road and climbs onto buildings. They can't delay gratification. They act on the first thought. It was a really good idea to put a cardboard box over my head. There can be speech problems. They clutter speech and the information dump. They will start in the middle of the sentence and work outwards. They can annoy their friends with interruptions and disturb their play. So for all of these things, it's very difficult for the child and the family and for the adult. So thinking about the incidence and the prevalence, in the UK, a research survey of over 10,000 children between the ages of 5 and 15 found that 3.6% of boys and nearly 1% of girls had ADHD, around about 4.5%. The global prevalence is thought to be 5% of children with a ratio of 2 to 1 boys and girls. In adults, it's 2.5% of adults, with a ratio still higher in men, lower in women. The reported numbers differ between countries and treatment centres because professionals have different criteria for impairment versus symptomology. And of course, between 50 to 65% of children show some impairments progressing into adulthood. So we see adults with this as well. Girls might be unrepresented and undiagnosed and might have the more inattentive type symptomology than the hyperactivity impulsive type. So looking at the pattern worldwide, we seem to have need to go back there. Can we go back? We can. We could briefly. Right, okay. We've gone back to, no, we've lost it entirely now. Sorry. There we go. Let's stay with this and I won't wiggle my mouse about too much. When we look at the global prevalence, we find that in the USA, it's overrepresented and overdiagnosed. When we look at France and Northern Ireland, it's around the 4 to 5%. Netherlands, similar, a little lower. But in some countries, say Romania, Poland, it is very much underdiagnosed. There will be children there who are not diagnosed, who are not treated appropriately. So think about treatment options. Well, one mother said to me that the first thing she did was to buy her child a trampoline, which was very, very useful. And we do have a range of options, certainly in sort of psychology, occupational therapy, speech and language therapy, and possibly the most important of those are school-based interventions, so helping the child to concentrate and keep on task at school. But of course, we also have medication, which I find useful in my clinic. Some children cannot cope without medication. Thinking about the numbers of children, again, we have reports from the USA, so they would tend to over-medicate. Of the 77% of children receiving treatment, 30% were treated with medication alone, and 32% additionally had both medication and behaviour intervention. So in the United States, there is a lot of medication going on. So what medications are used? Well, we have the stimulants, and they're the most effective, but tend to lead to a reduction in appetite. And when you look at the side effects of all of these, it is loss of appetite, poor weight gain, nausea and vomiting. Yeah, nausea and vomiting, poor weight gain. We can also see use of non-stimulants. The selective noradrenaline reuptake inhibitor is the one that's most used, perhaps in the UK. And the children that I work with will say it's less effective, but they have better weight maintenance. They have more of an appetite. But again, the side effects here are nausea and vomiting, loss of appetite, and suicidal ideation. And I have had one child who has had that as well. These other medications are used but rarely, and they weren't designed for ADHD. But again, their side effects, nausea, abdominal pain. So with all the medications, we have an impact on the child's appetite. So what are the general issues that children and parents are facing? They find that their attention is distracted. They can't direct their attention to what's teacher is saying in class. They're distracted by other children in the class and what they're doing. They can't concentrate on the task in hand. Yep, if I concentrate on concentrating, I can't concentrate, basically. They need to make a noise, to fidget, to move constantly. They can't be left alone to play by themselves. I have to concentrate to stop myself from moving my leg. I say, do you want me to sit still or do you want me to do the work? I can't do both because I'm concentrating on sitting still. Those are from children that I work with in my clinic. They might show aggressive behaviour or disruptive behaviour in the classroom. They do the first thing that comes into their head. I just got bored, so I took his book away and threw it. Yeah. He just hits me for no reason. He took my phone away and threw it because I wasn't paying him attention. I climbed onto the hut and threw stones at the teacher. I don't know why. And from an adult, by the time I got to 15, I was taking drugs. So the core symptoms might also impact on eating behaviour, food intake, and nutrition status. This is more likely to be observed when medication is necessary. So stimulant medication reduces appetite and induces nausea, and this can often lead to poor weight gain and eventual growth stunting. And nutritional deficiency, the children that I work with, there's a high comorbidity with autism spectrum disorder and ARPID, avoidant eating. And where appetite is poor, then foods that are accepted will be those that are highly palatable and processed, and the diets are often deficient in protein, fruit and vegetables. So I will have children on a diet of biscuits and chocolate buttons. So in summary, approximately 5% of children will be diagnosed with ADHD, certainly in Eastern Europe. This will have an impact on the child, their education and their family. Sorry, that should be Western Europe. Many will need medication in order to gain stability. The side effects of the most effective medications are appetite reduction and weight loss. And some of these children will also have ASD and avoidant eating. Their dietary range and appetite will already be reduced. So it is therefore important to assess and manage the child's nutritional needs if they're diagnosed with ADHD. So our next speaker then is Dr. Ingrid Rasmussen. And Ingrid has more than 30 years of experience in paediatrics, of which 26 years have been in neuropsychiatric investigations and almost 20 years in pharmaceutical treatment of neuropsychiatric disorders in children from 0 to 18 years, and including investigations and the treatment of disorders such as ADHD. She also has extensive experience in working with eating disorders in children, including anorexia nervosa, as well as obesity. She's held a position at a paediatric clinic in Stockholm since 1986, and from 2020, she's held a position at the Ryden Paediatric Outpatient Clinic in Stockholm. Her interest is particularly focused on the interactions, pedagogy, and compliance in both clinical setting and her professional practice.
Thank you for your introduction. I can't see you who's listening to me now, so I'll try to make this interesting enough anyway. My name, you've heard, you can call me Ingrid. The family name is difficult to pronounce. I live in Stockholm and I've been working since the beginning of '81 with children in various ways. And as Gillian told you, I've been working for 25 years with neuropsychiatry disorders and also with other pediatric disorders. So I like 50% of each. I started at a hospital where I met a lot of diabetic patients, anorectic patients, and a lot of babies. And the interest of eating and the diets were easily woken. Then I started working in an out clinic, and that was at the time when Sweden started organizing teams to investigate neuropsychiatry disorders. At that time, we called it DAMP, DAMP, and that included also the motoric perceptual problems that a lot of these kids have. Later on, we've changed the names and we call it more ADHD or DCD and ADD in Sweden. Sorry. This is my poll question. Okay. No, I can say, sorry. Yeah, we go on with the poll question, I think. You can see them here. One of alternative is correct. I wanted to underline the common comorbidities in neuropsychiatric conditions is very important when you're a pediatrician, and I work with all these matters in my daily work at the clinic. Name 5 common comorbidities in neuropsychiatric conditions. Obesity, IBD, it's inflammatory bowel disease, encopresis, sleeping disorder, and diabetes. Or obesity, IBS, irritable bowel syndrome, headaches, incontinence, and sleeping disorders. And the third one is obesity, depression, headaches, constipation, and celiac disease. Yeah, most of you thought the second choice. And as you see, I've made it a bit difficult for you because in every choice there is rights and wrongs, except for the second one. Diabetes, I don't know of any comorbidity with ADHD, and not celiac disease either. I think it's very important to underline that the comorbidity in neuropsychiatry disorders, since I think it's very helpful in clinical care. There are pediatric comorbidity, as you can see, obesity, eating disorders, pain disorders, bowel issues such as not constipation, but encopresis mostly, urinary tract issues, and that is incontinence, both daily and when it's difficult to treat night enuresis, it's often linked to neuropsychiatry. Sleeping disorders is very common, and actually there is a genetic coincidence with asthma they found. And clinically, we thought there were many asthma children that had ADHD symptoms, and we thought it was because of the treatment, but it turned out to actually be a genetic link as well. And in child psychiatry, there is obvious comorbidities like autism, defiant disorders, anxiety, OCD, depression, bipolar disease, tics or Tourette, it's wrongly spelled, I see, and borderline disease. I think I clicked twice now. Yeah. As we heard from Gillian, the prevalence in the Nordic countries is like 3 to 7% in school children, and 3 out of 4 get pharmaceutical treatment, or at least starts with treatment, but sometimes it's not continued because I think mainly because of the eating problems actually. There are other side effects, but the eating problems are the most important, I think. The positive effects, of course, is that the child experience that they can succeed in school. And that's actually a very important angle of the problem, because they often come to me and feel like they are losers actually. And when they start performing better, when they are medicated, they feel so much better, and the long-term school outcomes of course becomes better because of that. They can be with their peers and friends and interact in a more socially acceptable way, not interrupting playing or talking, and be able to I used to call it push the button on themselves to start them from interacting in a badly way. Quality of life and life functioning gets better, of course, since social interactions gets better and school performance gets better. Side effect, there are many side effects, but the most common that is serious and is a big problem for both the family, the child, and the doctor is loss of appetite. and because of that they don't grow the way they should. And I think the appetite, you have to accept that that's there, but if they don't grow, we can be forced to discontinue the medication. So I think it's a daily struggle for the families and the child, and for me and my nurses. We work with that every day. And 1.6 times risk at being underweight compared to children without these problems when they are medicating. I think this is some sort of methodological advice. That's why I'm talking about all these factors surrounding the child and the family when it comes to health and social situation. And these are the things I'm asking about when I meet the child the first time, when we are starting an investigation. And the inheritance is so important, both in psychosocial matters and medical matters, since that is affecting the parents' way of handling problems at a daily basis and in the family. And when we start the investigations, we ask all these questions. The perinatal incidences, which is important both because the child could be of a premature child or a low birth weight child, and that affects the growth later on. The social situation to start with is so important, how the parents are handling all the problems that is coming with a child with ADHD. Traumas affecting the child during upbringing is very important, of course. Preschool event, we always ask about. School situation now, and activities when they are free from school, and how about friends. And when it comes to medical matters, you can see all the things I've written down. It's also the inheritance, of course, for diseases and problems that can come along the way. The psychomotor development, of course, if it's been all right, or if there's been a lot of obstacles on the way. I can tell you that I meet a lot of small children at my clinic, and they sort of have all these problems early on, like sleeping disorders or eating disorders, or being restless, even as babies and preschool children. So sometimes I keep them under watch and check them at like a 6 months or yearly basis, because later on they develop very clear symptoms of ADHD, and these parents need a lot of support on the way, and that makes the social situation so much better if somebody is like leading the way through preschool period. Other diseases that affects the child's growth and well-being, of course. Some children have a lot of infections during the preschool years, and they can't attend all the things they want to do and develop socially. Medication of other kind that could affect the child's well-being, of course. Self-care is something I've actually created that word for this special occasion, because I usually say to my parents I meet that there are like 10 things you want your child to know when he is old enough to move from home to be on his own. And it's like the hygiene thing, the eating, um, to be able to follow a schedule, to keep order on your things, a lot of things that you need to know when you're on your own, when you're an adult. And I always check all these things, because eating is part of that self-care. Do they eat breakfast? Do they eat lunch? What do they like to eat? Could they sit for a couple of minutes together with other people to eat? Or are they running along as quick as possible? Growth before doing this investigation, and treatment is very important to know about. And when we see the children and doing the investigation, we always check some medical matters to exclude, like thyroid gland disease or celiac disease or anemia for some reasons. And if they have got a previous history of eating disorder, it's very important to know in the beginning of the investigation, I think. If they have sleeping disorders and eating disorders, I try to deal with them before they go through with the investigation to make it easier to work with it if it's if they are getting a diagnosis and they will start on medication later on. So eating habits, as I just said, the children who has got neuropsychiatry disorders have got a lot of issues, I should say. They don't always eat all the meals, and I give them like homework to do. If they meet me, I could be quite a severe doctor, and I say, your homework to next session is to start eating breakfast, because I'll meet a lot of children that don't eat breakfast. And some of the children are not eating lunch at school. There are various reasons for that, but it's very important to eat the lunch at school. And in Sweden, the parents' taxes are paying for the school lunch. So that is also a reason to eat the lunch, because you've already paid for it. I actually use that argument. Are they eating extra meal? Are they picky about food? Have they got oral difficulties? Are they children that are in fear of many things, like medical tests? That is something that is good to know before starting treatment. I want to talk a little about overeating. I'm not sure if I come back to that. Yeah. No, I don't. The obesity is quite common in children with ADHD, actually, and even more common in children with ADD. And I used to say, I was a bit surprised starting doing this for 20 years ago, that I met quite a lot of overweight children with ADHD and ADD. And I used to say that they eat faster than they run. It was actually children that was quite overactive, and they often had sport activities like football or hockey, whatever, but they actually were overweight, and some of them were obese. And they are sort of having this impulsiveness in eating. So they manage to eat a lot of things before they feel full. So that is the contrary to the other group when it comes to treatment, I think, because you could affect the impulsiveness with the medication. So it's both a central effect on the appetite, and as well as it's an effect on the impulsiveness when you have central stimulants. And that is actually helping the overeating child, because the appetite usually comes back easier on the obese children, but the impulsiveness is regulated by the medication, and they can control the things about eating that we have tried to teach them. Some of these children have been at the clinic before getting the ADHD diagnosis because of their obesity. So they can have been for years under our care, and then we actually can see that they have a neuropsychiatry disorder, since that is quite common, actually. More common than we know, I think. I've only got a couple of minutes. As I just said, I think it's a good prognosis if you see all these things I've stated here. The child likes eating in general. The family has got a good structure. Family is interested in cooking. Obesity actually makes it easier. motivation for medication, and that you're careful as a clinician about preparing before medication, and good clinical support. It's more likely a challenge if there is a inheritance of eating disorders in the family, social distress in the family, the child has a pickiness, that you haven't got the time to prepare meals and eat together, and if there is a poor or ambivalent motivation. 9 out of 10 children with ADHD have problems with food intake in everyday life. 2 out of 3 parents are worried that their children with ADHD don't get enough nutritious food. I think a lot of the parents are very worried about this side effect, but they are often even more worried about ADHD medication all over, I should say. There is a lot of difficult thoughts about the medication, at least in Sweden. I should say, like, at least 1/3 of the parents are worrying about the medication, not only by the loss of appetite. And almost all parents experience stress about the food intake. I think the first year, almost all the children have got problems with their appetite, so they need a lot of support from the clinic. I think I'm a bit late, so I won't talk a lot about this. This is important things about growth. It's a bit of more another medical field, you can say, but you have to have a grip about that when you are having children that are supposed to medicate with ADHD. So you have to weigh in all these factors when you treat children with ADHD. So I try to prepare that when I do the investigation. So we start working with that to begin with, even though we don't know if they have got a diagnosis. The growth chart is one of the most important tools that a pediatrician or a pediatric clinic has got, for all the reasons when you have got children to treat. So that is a task for all of us to deal with. I think I have to speed up. The MP team and nutrition support, I think they should have a basic dietary advice to start with, and that there is a possibility of having oral nutritional supplements. And I think the need is even more if you haven't got a lot of food skill in the family. That we work together, all the professions that are linked in with these questions, and that we could refer. Yeah, I think the time is, yeah, I can continue. Okay. Well, it's important for me. I think the most children we have with chronic diseases need all these teamwork and collaborations. I think it's really important, and without the nurses we wouldn't be able to treat these kids at all, I think. So in Sweden, at least, we usually have very skilled and educated nurses that could deal with all these problems. And the dietitians are never in the clinic in Sweden if you're not at a hospital. But if you're at an out clinic, you have to refer to a dietitian that is outside the clinic. But we work together with the dietitians, of course. We have the same computer system in Stockholm, at least, so we can see what we are doing. I think I'm out of time now, and I thank you all for listening.
Dr. Rasmussen, thank you very much for that. I found a couple of very interesting points for me. One, that children with obesity still show food responsiveness after they're given medication, something I don't observe. I don't usually work with children who are obese, but an interesting fact. Thank you very much. So our next speakers then are Dr. Irene Hoffmeyer and Esther von Ryden. And Irene has been a general paediatrician for 20 years and has special interest in social paediatrics, in particular ADHD, for the past 15 years. She specialises in paediatrics at Erasmus Medical Centre and later worked as a paediatrician at Brnovo Hospital, where she led the ADHD outpatient clinic for 10 years in a dual role as paediatrician and psychologist. In 2010, she founded the ADHD practice Peacher Bell, together with Britt Backer, where children are treated for ADHD and comorbidities. Esther worked as a food technologist for 15 years and then went on to study nutrition and dietetics. She's now been working as a dietitian in primary care for 9 years, and she has specialised as a paediatric dietitian. She enjoys helping children with food allergies, abdominal pain, underweight, and extreme avoidant eating behaviour. Thank you.
Hello, my name is Irene Hoffmeyer, and well, as I was mentioned, I have an ADHD clinic for the past 10 years, and since a couple of years we've been working together with the dietitian in our practice. I have no disclosures. Well, the previous speakers have talked a lot about the comorbidity of ADHD, and so I won't go and read these all out. It's important to realize that most of these comorbidities can cause eating disorders by itself. The three main aspects of ADHD, hyperactivity, lack of concentration, and impulsivity, can also cause eating problems. Impulsivity can cause overeating, constantly eating candies and snitching food, and overeating in the evening. There's another reason that children can become obese, especially when children also have a social problem, for example, with autism, and they're often being teased or bullied or excluded by their peer group. Parents tend to give them candy or chocolate as a consolation. And a lot of parents don't realize how much candy children can get in this way. Yeah, the undereating can also be a problem with the ADHD, and this can be caused by the hyperactivity. The child literally doesn't give him or herself time to eat. And when there's comorbidity with autism, they can also be very picky eaters, so they only like a couple of things that they want to eat. There's a lot of investigation going on in the intestine-brain axis, and what role this may play in autism. It's been made clear that people with autism have a different microbiome in their intestines, and the diet is often less varied and of lower food quality. This influences their microbiome. However, it's not clear whether the microbiome is already there at birth and it might cause the autism or the eating problem with autism, or whether it's the other way around, whether the deficient diet can cause the different microbiome. It's a big step for parents to start medication. So very often when they come to our practice, they've already tried many things. And in the past years, there's been a lot of discussion whether food influences ADHD behavior. From systemic reviews, it appears that a healthy diet makes ADHD children behave better. The question is, isn't this the case in all children? Some investigations show that ADHD children might be more often deficient in magnesium, iron, zinc, and copper. Now I have a question for you. Which diet or supplements have a positive effect on the ADHD? And then there are 4 possibilities: the fish oil capsules, Lto3 capsules, the red diet, or none of these are sufficiently researched. Yeah, well, as most of you think, well, I think there's most experience with the fish oil capsules, but it's not been investigated well. But I think the last answer is the one that's true. I think all of these need further investigations. I'm just going to tell you a little bit about these supplements. The fish oil capsules, omega-3, 6, and 9, and unsaturated fats. And the hypothesis is that there's disbalance between omega-3 and 6, which could give symptoms of ADHD. There are very few studies. One study showed some positive effect on the hyperactivity. Next slide. The Lto3 supplement, which contains amino acid cementus from fish and skullcap, which is a herb. And this would also reduce ADHD symptoms. It would also reduce fear and stress and improve sleep. Again, there are no good investigations. Then there's also people that think that that there are foods to improve the concentration, and some of these are mentioned above. In the past few years, there's also been a lot of discussion whether food colorings and preservatives might also have an influence on behavior. One investigation showed that a diet high in sugar and fats increased ADHD behavior. Something else that a lot of people are interested in is the restricted elimination diet. And this is a diet where in the first 5 weeks, you have a very strict elimination of foods, and there's a very slow introduction thereafter. Sometimes it takes up to 1.5 years to get a complete normal diet again. There's been quite a few investigations, but the results are not consistent. It's important to have professional guidance when following this diet. It's important to realize that it's very expensive. It costs about 1,450 euros to buy the diet, and the consultations are also expensive. There's a large investigation on different ages going on right now. Just recently, there's been a publication in Nature where the diet is being presented as the solution for ADHD. I'm a little skeptical about the diet myself for several reasons. Most often it's been tested in small children. And of course, since it's such a strict diet, they will have much more supervision with such a strict diet. And this will also influence their behavior. There's also a social problem. Children are not allowed to have birthday treats, for example. They eat a different meal from the rest of the family. Adolescents, they won't follow such a strict diet, and the diet is lifelong, so it's very difficult to maintain. When people do decide to start with medication, it's usually the methylphenidate and the dexamphetamine. In the list of side effects, it says that it's about 20% of the people that experience loss of appetite. In our experience, that's a little bit more often. And it's important to realize that the loss of appetite is usually only for the period that the medication works. So after, for example, if you give medication that works 4 hours, after the 4 hours, the appetite is back. And what can we advise to improve the eating habits while using medication? The 4-hour ones, it's important to emphasize that they take the pills after they've eaten. So after breakfast, after lunch and everything. For the 8-hour ones, it's also important to have breakfast first and then take the pill. And then, of course, they have to eat something when they come home from school. Obviously, with the 12-hour pills, that's a bigger problem. And it's also important to emphasize to the children and the parents that loss of concentration can also be caused by not eating all day. But unfortunately, the parents are more impressed by this than the children. What I find very important is that at every consultation, weight and height should be measured. And too little intake is not just a weight loss problem, but also there's stunting of growth. And I think it's very important to have a dietitian in the practice where ADHD is treated. Now I would like to introduce Esther, the dietitian, who will continue with the presentation.
Well, good evening. My name is Esther van Ryven. I'm a pediatric dietitian, and since 3 years now, I work together with ADHD Centrum Pietje Bel from Irene Hoffmeyer. Tonight, I will present you the case of Jasper. Jasper was referred to me by Irene because of weight loss, and When I first met Jesper, he was a 14-year-old boy. He was in the 3rd grade of secondary school. He lived with his parents and his sister. He does in his free time jiu-jitsu. He goes to the gym now and then, and he cycles to and from school. Recently, he got dental braces, and he was already a restricted eater. But since he had the dental braces, he ate even less than he did before. Well, the weight loss or his low weight, his underweight was not bothering him, but only that his clothes don't fit, and his mother is nagging that he has to eat something or he has to eat more often. That was bothering him. On the other hand, his mother, she was very concerned because she saw that Jesper was often tired. He had concentration problems, and sometimes she found him a little bit apathetic. When you look at this slide at the top, you see the energy requirements of boys between 13 and 18 years old. The energy requirement is divided in the rest metabolism. That means the energy for brain development, for heartbeat, for keeping warm, for the immune system. A small part is used for thermic losses. A big part is used for physical activity. And at this age, also a big part is used for growth. At this age, the energy requirements for growth are relatively high. When you eat less, the energy intake is less than the energy requirement. Then you're in risk of underweight. And growth is one of the first things that is compromised if there is insufficient energy intake. Of course, when you eat more than your energy requirement, you're in risk of overweight. And the energy intake of Jesper was 56% of his needs. In the table below, you can see that his requirement is around 2,700 kilocalories, but he only ate 1,500 kilocalories a day. His requirement of protein is 43 grams, and he realized 61 grams. So his protein intake is sufficient at this moment. The focus will be on energy intake, but protein intake must stay sufficient. So we keep that always in mind. I used the table of the WHO this table to calculate his energy requirement. As you can see, boys from 14 to 15 years old need 55.7 kilocalories per kilogram body weight per day. Well, his weight is 48.8 kilograms, so that makes 2,718 kilocalories that he needs a day. But it is calculated without the extra energy to catch up growth. That leads to my poll question. If you hear all this, do you think that Jesper is in risk of delayed growth of his length? Do you think yes, he is, with an intake of 56% of his needs? No, in the Western world, we never see an effect on length of healthy children. Well, it might be only in cases of an underlying disease that affects his growth, or well, maybe, but only if he lived in a developing country. Here, he can have enough energy intake. So please make your vote. Well, almost everybody think that Jesper is in risk of delayed growth. Well, I will come back to that later. I will show you his growth chart. In the Netherlands, we do not use the WHO growth chart, but our own chart. Developed with the National Growth Study of in 2010. As you can see at this growth chart, the blue line is the average line, and the green lines are the standard deviation lines, also known as the Z-scores. I use these charts because in the Netherlands, we have the cutoff points for underweight that are based on these charts. As you can see, this is the chart weight for length, that he was always, had always quite a low weight, but he recently, his weight decreased and went down to the -3 SD line. Well, under the -2 SD line, we say somebody is underweight. You can even better see it at the next slide. This is his body mass index for age, and you see it was always has been slightly underweight, but now he's in the category of severe underweight. At the next slide, you can see his length for age. Well, his length for age has always been at the plus 0.5 SD line. It dropped a little bit when he was around 12 years old, but it went up again to the 0.5 SD line. Well, when you look at this chart, you should say that, well, there is no delayed growth for Jasper. I will come back again to that at the end of my presentation. Can I have the next slide, please? I calculated the target height of Jasper. His parents are quite long. His father is 198 centimeter and his mother is 180 centimeters. Then his target height is 119 centimeters. That is at the +1 standard deviation line. His expected height at the plus 0.5 standard deviation line is 185 centimeters. The average weight for length is 59 kilos, and his actual weight is 48.8. So there is a big difference between the average weight and his actual weight. And the conclusion is that he is severe underweight. I also calculated his diet, and for macro and micronutrients, and beside the intake of vitamin C and vitamin B12, there is not enough of all the micronutrients in his diet, so he's also in risk of malnutrition. Thank you. There are different types of underweight. When you compare it to a normal height for age, you can be wasted, then you are thinner than normal. You can be stunted, then you are shorter than normal, or you can have a combination of wasting and stunting, and then you are thinner and shorter than normal. Well, in this case, Jasper is wasted. Maybe he can have a combination of wasting and stunting. Well, then you have to have a length that is with stunting, you must have a length that is below the -2 SD line length for age. Well, that's not the case with Jasper. So he's not really stunted, but it is questionable whether he will achieve his final length that suits him. Can I have the next slide, please? There are different consequences of severe underweight. There are short-term and long-term consequences. And when we look at this table, well, we can see that with the short-term consequences, the mother of Jasper said he was fatigued, lethargy, he had problems with concentration. And with the long-term consequences, well, maybe his growth is in height is reduced. And well, he's also in risk of nutritional deficiency. So it is important that an intervention is made for Jasper. Besides the energy intake and the intake of vitamins and minerals, I also look at the eating pattern. With children with ADHD, the eating pattern is often chaotic. Well, that is their meals are skipped because they're not hungry, or they are distracted, or well, they don't have enough time at school to eat something. And you can also see that in the eating pattern of Jasper. He only has a small breakfast. Well, he takes a snack and a lunch to a school, but he always takes them back home again and doesn't eat anything at school. He used to eat some peanuts when he came home, but because of his dental braces, he can't do that anymore. So now he eats nothing. He goes up to his room, does his homework, plays video games. And the first meal that he has again is his dinner. His mother said it was a normal dinner, but for a boy of his age, I found it quite a small dinner. And then in the evening, after 8:30 p.m., he gets hungry, but his parents don't allow him to eat much more. They say you should have eaten during the day. Now it's already late. You can't eat a lot anymore. Well, what did we do with Jasper? The first thing was to enrich his food, to add full dairy products, add some fats, to make the portions a little bit bigger where possible, and choose for products that were richer in energy at the meals that he was already eating. We also started with oral nutritional supplements because with an intake of 56% of his energy requirement, it is impossible to change that within a short period. And well, he also for concentration, for fatigue, but also to get more appetite, it is necessary to increase the amount of energy in his diet rapidly. And we also added some eating moments. You have 6 possible eating moments during the day, the 3 meals and 3 times in between. And he's going to try to eat something at every moment. So when the portions are not big, then you have something more often and it is easier to meet your requirements. We had frequent consultations to evaluate whether the changes have the desired effect. And we also talked about coping mechanisms. How can he manage to stick to the changes, also in difficult moments or difficult periods? When the Dutch Malnutrition Society has established standards when to advise oral nutritional supplements or tube feeding to hospitalized children. I use this also as a basis for children who are likely to have an insufficient intake for a longer period. Well, Jasper has an intake of 56% of his needs. And then food enrichment is advised. We did that to add fats and full fat dairy and things like that. But also oral nutritional supplements are advised, and to consider tube feeding. Well, that is of course with hospitalized children, with healthy children, they are able to increase the intake, and tube feeding is never considered. Don't hesitate to add oral nutritional supplements. Especially in the beginning of the treatment, it can give the parents, but also the children, a peace of mind that the intake of the energy and the intake of the proteins, the vitamins are up to standard, and changes can be made step by step. There's less pressure on the changes, so it's easier to do, and in a later period you phase the supplements out again. Some other tips and tricks for children with ADHD and when they don't have a lot of appetite is to start with the child. They often can mention something that they can already change, and well, when you start with that, the chance of success is bigger. It's also important to take away the overly concerns of the parents, because if they stay concerned about the energy intake, then they keep nagging about it. And especially with adolescents, well, that's not helping to change their eating habits. And in this case, an oral nutritional supplement can help to take away those concerns. Not everything has to be healthy. When they don't eat at all at school, that is undesirable. So if they can fit in something that is not very healthy, well, at this age, they all seem to like instant noodles, for example, or a pancake or a nut bar. Start with that. If they have eat something at a certain time, on a later moment, you can change it to something that is more healthy. Do it step by step. If you want to change everything at once, it is difficult to stick to it. When you do it step by step, it can become a habit. Eat something later in the evening. A lot of parents find it very difficult. That's because later in the evening, the children are going to eat candies, crisps, chocolate. But if you plan a meal, a healthy meal or a healthy snack, they don't graze for the unhealthy snacks, but then you have something that you together. This is what you're going to eat at that moment. Do it yourself. A lot of parents tend to follow their children with the food. They tell them that they should eat something, but the parents are not always around. So I always teach the children to think of it themselves, that they have to eat something and how they can do that. And it's very important that you monitor, because don't think that when the weight goes up, that you're done. There's often a relapse. There's a period of illness, a difficult period, a holiday period, and then they change their habits again. And especially when a child is still growing, or when it still uses an oral nutritional supplement, it's important to see if this is still necessary. Is it still enough to grow? Is it still necessary to use the oral nutritional supplement? And of course, there comes a time that you have to phase it out. So you keep monitoring what is the right time to do that. Well, when we look at Jasper again, when we see this growth chart, his weight for height again, you can see that his weight did increase. And you can see it even better at the next slide. That is the body mass index again, and you can see the with some ups and downs, Jasper has a healthy weight again. At the next slide, you can see that the length for age did increase, and it did even increase more than could be expected. It was long at a plus 0.5 standard deviation line, but since the intervention, it went up to the 0.9 standard deviation line. So that is a significant change. And that means that he was in delayed growth, and that also at this age, at the age of 14, 15 years old, we can still influence the height if they eat enough. At the next slide, you can see what we did. We increased the intake of Jasper. In the beginning, his intake was 1,500 kilocalories, and it's gone up to more than 3,000 kilocalories. At first, he needed 2 portions of the oral nutritional supplement, but we were able to stop this, and his intake is still sufficient for growth. He also changed his eating pattern. He has 5 eating moments now. The eating moment when he comes out of school is still very difficult for him. He doesn't think of it, but because his energy intake, his protein intake, and all the vitamins and minerals are sufficient, at this moment we leave it that way. The easy changes for him were the oral nutritional support. He just liked one taste, but it was okay for him to drink those 2 portions every day. It was easy for him to change, especially his breakfast, and take a meal later in the evening, because that were the moments that he was well, more or less hungry. Difficulties were in an exam period. He is very nervous, and then he has even less appetite than normal. He sticks to the eating moments, but the portions are very small in such a period. During the school holidays, Jasper stops with his medication, and he really has appetite. He's quite hungry. He eats a lot more than he does when he uses the medication, and in such periods, his intake increases, and also we see an effect on his weight in those periods. Well, that brings us to the take-home messages. It is important to measure weight. That's the take-home messages of Irene and me together. It is important to measure weight and height at every consultation with a pediatrician, at least twice a year. Low intake can also influence the adult height. Work together as a pediatrician and a dietitian for children with ADHD. Start dietary treatment step by step with the wishes and possibilities of the child. Don't hesitate to start with an oral nutritional supplement and phase them out later. Thank you for listening.